Assalamu alaikum. Okay, बच्चे our next topic is pituitary gland. So, what do we understand about pituitary gland? Uh, we are going to study now. So, pituitary gland is also known as hypophysis cerebri. It is located in the below the cerebral cavity in the sphenoid bone. There is a depression in the sphenoid bone that is known as sella turcica, that is present at the base of the brain. The size of the pituitary is 0.5 to 1 centimeters in diameter, and its weight is 0.5 to 1 gram. It is obviously located in the sella turcica at the base of the brain. This gland, pituitary gland, is connected with hypothalamus by a hypophyseal stalk or pituitary stalk. As you can see here, this is the pituitary stalk via which it is connected with the hypothalamus. So if we look at the brain, here is the cranial cavity, the cerebrum. Here is the sphenoid bone, that is a you can say a butterfly like structure, and pituitary is located in the sella turcica, or the depression that is present in the sphenoid bone just below the cerebrum, that is the brain cavity. Pituitary gland consists of two parts, that is the anterior pituitary and the posterior pituitary. Anterior pituitary is also known as adenohypophysis because it contains different types of cells which would produce different types of hormones which are endocrine in nature. And posterior pituitary is also known as neurohypophysis because it mainly serves the purpose of storing the enzymes which are produced in the hypothalamus and then transported to the pituitary via the hypophyseal hypothalamic portal system. The anterior pituitary develops from Rathke's pouch, which is an embryonic invagination of the pharyngeal epithelium. So when we will study the embryology, we'll study development of pharyngeal pouches. From one of the pharyngeal pouches develops a cavity that is known as Rathke's pouch, and this Rathke's pouch would go on to embed itself and attach with the hypothalamus. Whereas posterior pituitary develops from an outgrowth of hypothalamus. In some humans, there is another lobe that is known as intermediate lobe, but it is a rudimentary organ. That is, it does not serve any purpose. The main hormonal secretion is via anterior and posterior pituitary. Now let's talk about some hormones and their functions and where are they secreted from. So there are some cells which are present in pituitary which would release the growth hormone. The growth hormone releasing cells are also known as somatotrophs. So somatotrophs would release growth hormones. These growth hormones would act on almost all cells of the body and all tissues of the body and would help them in growing. So they help a child into becoming an adult. They help the bones of the children to mature and transform into the adult form. Growth hormone would help in increasing the height, the weight, everything, developing every structure of the body in a human being, in an adult human. Then there are other cells which are known as corticotrophs, which would release the adrenocorticotropin or adrenocorticotrophic hormone. Okay, so the growth hormone is secreted via action of growth hormone releasing hormone that is released from the hypothalamus, that would act on pituitary and then release this growth hormone. The adrenocorticotrophic hormone is released by action of pro-opiomelanocortin, that is a hormone which is produced by the hypothalamus, and it would act on the corticotrophs, which would release this ACTH, adrenocorticotrophic hormone. Moreover, it would produce melanin as well as some other compounds. So this ACTH would act on the adrenal cortex and would secrete adrenocortical hormones from the adrenal cortex. These hormones help in regulation of our blood pressure and regulation of sodium absorption and water reabsorption from the urine that is being produced in the kidneys. Then there are cells which are known as thyrodrops. Thyrodrops would release the thyroid stimulating hormone. This thyroid stimulating hormone would act on the thyroid gland, and the thyroid gland would in turn secrete the thyroxine and triiodothyronine, that is T3 and T4. Then there are gonadotrophs. Gonadotrophs release follicle stimulating hormone and luteinizing hormone. Follicle stimulating hormone causes the growth of follicles in ovaries in females prior to the ovulation. So maturation of follicles in the female ovaries would be under the effect of follicle stimulating hormone. Follicle stimulating hormone also promotes the formation of sperms in testes in males. On the other hand, the luteinizing hormone is also produced by the gonadotroph cells in the pituitary gland, and this hormone plays an important role in causing ovulation in females and also causes secretion of female sex hormones by ovaries, that is estrogen, and it would also cause release of testosterone by testes in males. Then there are lactotroph cells in the pituitary which would release the prolactin. Prolactin is a hormone that would promote the development of breast and secretion of milk in females. There is a benign tumor of these lactotrophs that is known as prolactinoma. It is a benign tumor of pituitary in which there is increased production of prolactin. If this condition occurs in males, it causes improper development or increased development of breast in males. Okay, so then there is antidiuretic hormone that is released by posterior pituitary. It is in fact produced in the hypothalamus. It is produced in supraoptic nucleus in the hypothalamus and then transported towards the pituitary through the portal tract, and then it is released from the pituitary and it causes the kidneys to retain water in higher concentration that would cause vasoconstriction of blood vessels, and it would cause production of more concentrated urine. That is, the urine which has less water, it is more concentrated. Moreover, the posterior pituitary also releases oxytocin that is produced by the paraventricular cells that are present in hypothalamus. This oxytocin is then transported to the posterior pituitary and stored and released from there. Oxytocin would cause the contraction of uterus during birth process, during parturition, and it would also help in contraction of myoepithelial cells and thereby help in expressing of milk. So when the baby sucks on the chest of female, this oxytocin is released from the posterior pituitary, and it would act as a stimulator of milk production or release secretion of milk from the breast. Okay, so let's talk about the posterior pituitary. The posterior pituitary gland is also known as the neurohypophysis, and it is mainly composed of glial-like cells which are known as pituocytes. The pituocytes do not secrete any hormones. Remember this point, they do not secrete any hormones. They simply act as supporting structures for nerve tracts that are arising from the hypothalamus. The hormones of the posterior pituitary are basically produced by the hypothalamus. These tracts would pass to the neurohypophysis through the pituitary stalk, that is the hypophyseal stalk, and secrete two hormones of posterior pituitary, that is oxytocin and antidiuretic hormone. So the paraventricular nucleus would produce the oxytocin and the supraoptic nucleus would produce the antidiuretic hormone. These hormones are transported via hypothalamic hypophyseal tract to the posterior pituitary and then stored and released from there. So they are merely facilitators, they are not production chambers of these hormones. Antidiuretic hormone is also known as vasopressin. It would cause increased blood pressure, it would cause increased retention of urine within the body, and it may cause edema if it is produced in high concentrations. Okay, so the site of secretion is the 5 out of 6 part from the supraoptic nucleus and 1/6 from the paraventricular nucleus. This is for the antidiuretic hormone. So antidiuretic hormone is basically secreted from the supraoptic nucleus, but some of it is also secreted, produced by a paraventricular nucleus, and it is a peptide hormone in nature, also known as nanopeptide. So let's talk about the effects or functions of the ADH. The most major function of ADH is the antidiuretic effect. Diuresis is production of more urine or more diluted urine. Antidiuretic means production of concentrated urine or production of less urine. So it causes water retention, that is water reabsorption from the collecting ducts in the kidneys. So it is produced from the produced from the hypothalamus, transported to pituitary, released by the pituitary, then travels through the blood, goes to kidneys and acts there on kidneys. Antidiuretic effect occurs in low doses of antidiuretic hormone, and it would result in the urine becoming more concentrated and decreased volume of urine. Moreover, osmotic pressure would be decreased within the body, and it would result in dilutional hyponatremia. So what happens is, as more and more water is retained within the body, it would cause increased water content and decreased sodium in the blood. This condition is known as dilutional hyponatremia. So let me phrase it again. Water is absorbed in more quantity from the collecting ducts and it dilutes the sodium content of the blood. Normally it should be enough, it should be in normal range. But if antidiuretic hormone is absorbing more water from the urine into the blood, it would cause dilutional effect in sodium concentration. So sodium concentration would decrease and this would cause dilutional hyponatremia. Moreover, there are pressure effects of ADH, that is, if released in lower quantities, it would cause retention of urine. But if it is released in higher quantities, it has a very potent effect, very strong effect on constricting the arterioles throughout the body. So smaller arteries, they would constrict, decrease their size, and as a result arterial blood pressure would go up, so the blood pressure would increase. For this reason ADH is also known as vasopressin, because it's pressing the vessels. One of the stimuli for causing intense ADH secretion is decreased blood volume. So whenever a patient is undergoing hemorrhage, that is bleeding, it may be internal or external after some sort of injury or some sort of pathology. So what happens is, whenever bleeding is occurring on a large scale, it would trigger release of ADH on massive scale, which would cause sudden constriction of arteries, arterioles, and it would result in increasing the blood pressure, stabilizing the blood pressure of the patient. So how does the ADH work? ADH goes and attaches to the kidneys, collecting tubules, and it would convert the ATP into cyclic AMP. So ADH works via cyclic AMP pathway. It works via GS type of receptors. This cyclic AMP would cause the activation of aquaporins, which are small mesh-like openings within the collecting ducts of the kidney. This would cause reabsorption of the water from the nephron. So water from the nephron would rush to the collecting tubular cells, and finally it would rush towards the blood. So in the collecting tubule, it would cause reabsorption of water via releasing cyclic AMP. Alright. Okay, so let's proceed. So how is the ADH controlled? Okay, which there are two conditions in which either ADH is released in low quantities or high quantities. I'll just teach you these conditions when we study pathology, but right now you just need to know their names. One is SIADH, that is syndrome of inappropriate ADH secretion, and the other one is diabetes insipidus. So in one condition ADH is produced in huge quantities, in other condition ADH is produced in very low quantities, so abnormal production. So how is ADH secretion controlled? It is controlled via osmotic regulation, that is the supraoptic and the paraventricular nucleus are osmoreceptors, means they detect the osmolarity of the blood. and they increase and decrease size in relation to changes in osmolarity of the extracellular fluid that is present in between the cells. So when the osmolarity of the ECF is low, so when the fluid in the extracellular fluid is more dilute, that is low in salt, sodium and high water content, the osmoreceptors would swell and decrease the secretion of ADH, because we do not need any more water to be stored in our system. That is why the ADH secretion would decrease, so as to prevent absorption of more water. And when the extracellular fluid volume osmolarity is high, that is more sodium content and less water content, then we need to conserve water to treat this hypernatremia condition. So ADH would be secreted in larger quantities so as to uh, push more water into the extracellular fluid, so as to conserve more water in the body. So if we are drinking excessive water, then it would lead to increased plasma volume, that is low extracellular fluid osmolarity. So understand this concept. We are drinking more water is storing into our body, and the sodium concentration in the extracellular fluid is getting low, water concentration is getting high, and as a result osmolarity is getting low. Osmolarity depends upon the substances which are present in a fluid. So the less the substances, more the fluid, lower the osmolarity. More the substances, less the fluid, osmolarity increases. So if we drink excessive water, it would lead to increased plasma volume and low extracellular fluid osmolarity, and it would also decrease the ADH secretion. Antidiuretic hormone secretion would also decrease, which would lead to decreased water reabsorption from the kidneys and production of more and more urine. Why does this occur? Because there is more water, less sodium in the body. We need to excrete out water so as to uh, um, manage our sodium content, so that the sodium gets normal. So we excrete more water and the sodium comes to its normal value, that is 135 to 145 milligram per deciliter. If the sodium gets lowered than 120 milligram per deciliter, you may start getting convulsions, you may go unconscious, so it is very tightly monitored. Recently I told you to pray. That is when my sister was admitted in the hospital in the ICU. She had severe symptomatic hyponatremia, that is decreased sodium content. Her serum sodium level, the normal is 135 to 145, hers was 104 millimole per liter. So that is a life threatening situation. Moreover, we cannot increase the sodium content steadily. Means we need to increase the sodium content by 7 to 11 millimole per liter per day. So it is increased very slowly. If we increase the sodium content too fast, it would cause central pontine hemolysis, that is the brain death. The patient would not survive. Moreover, ADH secretion is controlled by exteroceptive stimulation, that is via pain, emotional upset, exercise or vomiting. ADH secretion is increased. So remember this. Whenever we are feeling more pain, we are emotionally upset, exercising or vomiting, we conserve more water in our body. via increased ADH secretion. And certain drugs such as nicotine, morphine, they increase ADH secretion, whereas alcohol decreases ADH. That is why in alcohol drinkers the urine production is too much. There is dilute urine in huge quantities in alcohol abuses. It is because of this reason the ADH secretion gets inhibited. So there are osmoreceptors which are present in or paraventricular nuclei and supraoptic nuclei. If the osmolarity is decreased, there would be more ADH secretion. If the osmolarity is decreased, there would be less ADH secretion, and if the osmolarity is increased, there would be more ADH secretion. So supraoptic and paraventricular nuclei synthesize ADH and release it, and posterior pituitary stores it and then secretes it into the blood. This would in turn cause release of ADH, which would go on to act on the collecting duct and increase the water reabsorption. By increasing the permeability of renal collecting ducts, water is reabsorbed passively. Moreover, it is also controlled by stretch receptors which are present in the arteries in the heart. So what happens is, when there is increased volume, that is, there is more stretching in the heart or the main arteries, it would cause less ADH secretion, and if the stretch is lowered, there would be more ADH secretion. So let's finish this ADH today, I think. So there are two clinical conditions which are related to the ADH secretion. In one condition there is increased ADH secretion, in other one there is decreased ADH secretion. So what happens if there is excess ADH? This condition is known as SIADH, or syndrome of inappropriate ADH secretion. In this condition there is excessive extra secretion of antidiuretic hormone that would cause an excessive reabsorption of water in the renal collecting ducts. It may be caused due to lung cancer or due to several diseases. Excess ADH secretion would lead to more absorption of water, and it would lead to dilutional hyponatremia and water intoxication. Do you know volume overload or water intoxication is a pathology? If you drink too much water, do not go for urine, you may die, as it has already happened to a person. There was a contest for a video game console, that is the Nintendo Wii, and the contest was about who can drink excessive water and then hold the pee. So you cannot urinate and you need to drink excessive quantities of water, large amounts of water, and if you hold it for too long, you would win that console. A woman took the challenge and she died of complications due to water intoxication. Okay, so this was SIADH. The other condition is known as diabetes insipidus. The spellings of insipidus are not right. So diabetes insipidus is a condition in which there is decreased ADH secretion. That is ADH deficiency. or decreased activity of ADH at the target organ. So it may be primary or secondary. Primary diabetes insipidus is when there is no ADH secreted or less ADH secreted from the pituitary or the hypothalamus. Secondary is when the ADH is ample, it is adequate, but it is not acting on the kidneys as the ADH receptors present on the kidneys are faulty. So it is another thing that could happen. The symptoms for diabetes insipidus would be passage of large amounts of dilute urine, that is known as polyuria, and drinking large amounts of water, that is known as polydipsia. So the urine is dilute and produced in large quantities, and the patient would drink large amount of water. It is just like diabetes mellitus. Diabetes mellitus literally means sweet urine. So the sweet urine due to presence of high glucose content in the urine is diabetes insipidus, and diabetes is diabetes mellitus, and diabetes insipidus is tasteless urine. So or urine fountain. Okay, so tasteless fountain kind of thing. So what happens is the patient is just urinating like a fountain, but it does not have any taste because it does not contain glucose. So primary diabetes insipidus is also known as the central neurogenic diabetes insipidus, in which there is disease in the hypothalamic nucleus, that is the supraoptic nucleus, or the hypophyseal tract or the posterior pituitary gland, and sufficient ADH is not available to affect the renal collecting ducts. The treatment of this condition is possible through giving injections of vasopressin. Whereas nephrogenic diabetes insipidus cannot be treated because there is genetic problem in the receptors for ADH on the collecting ducts, and kidneys cannot respond to ADH even if it is given in highest quantities. Kidneys would not respond to ADH, and hence vasopressin would have no effect in this kind of patient. Okay, so the next hormone would be oxytocin, and we'll inshallah learn it in the next lecture. So take care. Allah Hafiz. If you have any questions, you can post them in the group. I'll reply to all of your questions inshallah.